Hello, and welcome to the National Press Foundation's Evelyn Y. Davis Studios in Washington, D.C. My name is Rachel Jones, and I'm the Director of Program Initiatives with NPF. Thank you for joining us for the COVID and Flu Vaccine Updates Explained webinar, sponsored by Champions for Vaccine Education, Equity, and Progress Initiative, or also known as CVEP. It's a diverse network of 250 plus partner organizations with research and resources to answer urgent questions about the latest vaccine related guidance. CVEP's new Stay Updated campaign has resources in English and Spanish and information to help you learn more about the need for updated COVID-19 and flu vaccines. For more information, you can scan the QR code or go to cveep.org. There's no debating that the public's need for accurate information about the role of vaccines and the ongoing need to protect against emerging viral strains. There's also a lot of concern about boosting our protection against the flu. Today's webinar will explore these issues during a conversation with four leading experts. And for everyone tuning in, you can submit questions for these panelists at any time in the chat or by using the Q&A feature. We'll get to as many of them as we can. First, let's introduce our panelists. We're joined by Dr. Bertha Hidalgo, an associate professor in the Department of Epidemiology at the University of Alabama, Birmingham. Dr. Hidalgo's research focuses on health disparities related to COVID-19 and on cardiometabolic diseases and science communication, with a special focus on Latino populations and on genomics. Next, we'll hear from Dr. Ariangela Kozik, an assistant professor in the Department of Molecular, Cellular, and Developmental Biology in the Department of Internal Medicine at the University of Michigan. Dr. Kozik is also a co-founder and vice president of the Black Microbiologists Association, and she believes that increasing public engagement with science and the scientific process is critical to a thriving society. We'll also hear all the way from Munich, Apurva Mandavili, a global health reporter with the New York Times. She shared in the paper's 2021 Pulitzer Prize for Public Service for coverage of the pandemic, and she was also a member of the team that was a finalist for the 2021 Pulitzer Prize for National Reporting. She is the 2019 winner of the Victor Cohn Prize for Excellence in Medical Science Reporting, and she's won numerous other awards for her work. And last but not least, we're joined by Dr. William Schaffner, a past president and medical director of the National Foundation for Infectious Diseases. He's also a current spokesperson for the organization. Dr. Schaffner has served as NIFID liaison to the Advisory Committee on Immunization Practices at the Centers for Disease Control and Prevention. And he's also authored or co-authored more than 400 published studies, reviews, and book chapters on infectious diseases. You can read the full bio for all of our speakers on our website at nationalpress.org. I want to start with you, Dr. Schaffner, because of your depth of expertise and your perspective throughout the pandemic. As you stated during our first conversation, at the start of COVID, researchers like you opened the medical books to try to figure out what was going on and get information. And what did you find? Absolutely nothing.
Right.
So please get us started with a sort of a top-line overview of some of the most important things we've learned and what we need to know about where the science is taking us.
Rachel, I'm not so sure exactly where to begin, because we did open up our textbooks to COVID and we found a lot of blank pages. Actually, in response to COVID, I think the world's research community, public health research, basic laboratory research, as well as clinical research, has been extraordinary, and the exchange of information has put us in a much, much better place. As we all know, very, very quickly, the research community got together. was able to sequence the virus, work on establishing and creating a new vaccine was done in record time. That speed actually gave members of the public anxiety, while it actually at the same time gave us a lot of satisfaction and enthusiasm. Our diagnostic tests were quickly established. Can you imagine? Within a matter of months, we had a test that could be sold over the counter to pharmacies and delivered into the hands of individuals to actually test ourselves whether we had COVID. Just extraordinary capacity of our scientific establishment. Clinically, we had to learn about how it was this virus affected our body's not only immune system, but general inflammatory response and its biochemistry. And so at the beginning, people got just terribly sick. Now we're seeing people admitted to the hospital who are leaving, as I like to say, vertically rather than horizontally. That clinical information was also shared, and the research done by the public health community regarding the epidemiology of this virus also contributed extraordinarily to our understanding. So we've filled in those pages of our textbook. We're past the pandemic phase. We're now in the endemic phase, right? The CDC tells us that over 95% of our population has now had some experience with this virus, whether directly through infection with the virus or the vaccine or both. So our population immunity in the United States has increased substantially. And of course, the virus itself has mutated, and we'll hear from our colleagues more about that. We're now in the position of experiencing a summer bump. Unlike influenza, which essentially disappears during the summer, it's like a one-humped camel. COVID doesn't entirely disappear. It has a summer increase in addition to what we see in the fall and the winter, which is more substantial. So COVID is more like the two-humped camel. And we reviewed our local data just this morning before the call. And yes, here in Middle Tennessee, where I'm located in Nashville with Vanderbilt, we're also seeing a more sustained summer increase at the moment. So that's kind of where we are. And I leave it to my colleagues to elaborate on all of these things.
We will definitely be doing that. And I'd like to now pivot to Dr. Kozik. I'd like you to start by telling us a little bit about the evolution of the Black Microbiologists Association and give us the organization's core objective when it comes to educating the public about vaccines.
Sure. So BMA was created in 2020 in response to the lack of representation and visibility of Black microbiologists. And so the pandemic, as we know, was disproportionately impacting communities of color, especially early on. The information ecosystem was changing almost daily. As Dr. Schaffner said, we had all this information coming in really quickly. The scientific community was taking that information, working with it, moving things along. But from the public's perspective, it did induce a lot of anxiety. And we saw our communities really trying hard to sift through all of that information to understand, what was happening, how to best protect themselves, to deal with the uncertainty in the environment that was happening. And so what we have done through BMA was really just build a community of professionals and scientists in training from across both the academic and the private sectors so that we can have a community to network with each other, but also to move towards one of our core goals, which is to use our expertise as a resource for our communities and the general public so that we can share clear and accurate information, especially as it's related to topics related to the pandemic, but also other emerging microbiological issues.
I'm really grateful that both you and Dr. Hidalgo have joined us because I'm thinking it'll give us a great opportunity to delve a little bit more deeply into that particular topic. So, Dr. Hidalgo, I'd like to talk with you about what we're hearing among the many sorts of headlines that the public is getting about the, quote, summer wave. What do journalists need to communicate to communities about this new era of COVID? And is there a link between the emergence of these new strains and the increase in cases?
Great questions, and thank you for the opportunity to be here. I will say that I had an interesting conversation with my own husband recently, who was exposed to and ultimately had COVID, and I asked him to go to the store, and he bought a test kit, and I was out of town, and so he had taken the test over time, and the tests have a C and a T on the little cartridge that comes in the package. And initially he thought that the C was for COVID. And what that brought to mind is that we still have a lot of reminding to do, but also clarity to add about what things mean, explaining, adding definitions and context. And I think journalists, in my experience, have done a really fantastic job of getting that context and getting information from scientists and clinicians and a number of other people, public health practitioners that are actively working in these areas to make sure they're getting the public the information they need in order to effectively manage if they get infected, but more importantly, I think prevent infection. And so to the extent that people also understand when we have new variants that are circulating and what that means, for example, what does this two-hump camel mean in the context of when we might be most exposed to circulating variants, I think is really important to communicate to the public. And in ways that I think are accessible, but also very clear so that people aren't left with more questions than they originally had.
Apoorva, you as a journalist who has been at the front lines of coverage about COVID, I'd like to ask you to start by describing your journey as someone covering it from the beginning and how your imperatives and what you have to do now are different when it comes to communicating science.
Well, thank you for including me. It's a super interesting topic. As you can imagine, I think in early 2020, there was so much to write about all of the time. You know, Dr. Schaffner mentioned the textbooks were empty, and that's really tough when you're trying to be a reporter and asking experts who also don't know the answers. So if I paint in very broad brushstrokes, I think there were three things I was trying to do simultaneously. One is to fill in those gaps as quickly as they were trying to find out information. You know, what is this virus? What does it do? What is it doing to our bodies? What does the disease look like? What treatments might be available? All of the information that was coming at this breakneck speed. And, you know, we can talk more about how the reporting itself changed during that time to accommodate that kind of pace. And then the second stream was helping people figure out how to protect themselves, you know, how to test themselves, how to isolate, how to quarantine, how to, you know, what to do if they did get sick, and how to know if they were going to get sicker. And then the third stream, which I find, you know, incredibly compelling to do, and I think is very important and something really only journalists can do, is to hold public health agencies and public health experts accountable for what they were saying. And in 2020, to me, the most important thing that needed to happen, and the thing that I'm probably most proud of in the reporting, is to get the public health agencies to acknowledge that the virus was airborne. So if you recall, in the early months, we were being told this is only spread by droplets that are on surfaces, by contact, et cetera. And the researchers that I was talking to in Asia that I knew from having reported on SARS before and bird flu were saying something different. And so a lot of my reporting those months was also in trying to understand why they weren't acknowledging it. And then in July, the reporting actually pushed the WHO, the World Health Organization, to change its stance and say, okay, yes, the virus is airborne. And so I think that is something really only journalists can do. And if you now come, you know, 4.5 years later, COVID is not as much of a burning issue. It's still very important. But you mentioned I'm in Munich. I'm at an AIDS conference, so I'm actually getting to write about other infectious diseases that I neglected for a while. And I've also been reporting a lot on bird flu. But I feel like it's my job to also remind our readers that COVID is not gone. And so I still write about the summer wave, for example, and what people should do to protect themselves, why it's still important for people to get vaccinated, even if they may not be at risk of ending up in a hospital. All the things that maybe people don't want to think about anymore, but really should be.
Let's now sort of drill deep on the issue of variants. And many people are seeing the headlines that say new variants emerging, and we're seeing the word flirt in the headlines to describe them. Dr. Schaffner, let's start with you to give us sort of a primer on the emergence of these new variants and what they mean.
Well, I think one of the things that we have learned is that these viruses mutate. I think the public was generally aware of that regarding influenza. We've had to learn ourselves, and of course, teach the public that COVID can do that also. And I think a little bit to our surprise, COVID is mutating even more quickly, more rapidly. It's adapting to the environment more speedily than even does influenza. And now we've gone through a number of different phases with dominant viruses. We're now in the Omicron phase, highly contagious variants that apparently don't produce more severe disease, but they do produce a great deal of milder infection. And given the fact that we have widespread population immunity, as these viruses spread, they encounter this immune system and they adapt. And so that, if anything, stimulates further mutation. And we're getting a succession of these variants. You can think of them as children and grandchildren and great-grandchildren of the Omicrons. And so far, knock wood, we have not seen a new dominant, more serious variant evolve anywhere in the world in recent months. Very, very good. Not one that is more serious and that can evade the protection that we have currently provided ourselves through vaccines and previous experience. So far, so good. We do have to adapt ourselves to the fact that COVID is not just going to disappear. I think there are many members of the public who would like it to just go away and not think about it. And as Apurva has said, we have to keep reminding people that COVID is with us. One of the things that I've discovered, I would love for her to comment, is that as we learn information and our guidance changes or adapts to these changes, one of the most difficult things I've seen is that the public has to keep doing, if you will, its homework. It has to keep up. And that's been difficult. People like to think about other things. Politics is in the news now. Why think about COVID? So it's hard to persuade people to keep up with us.
Dr. Hidalgo, let's talk about influenza, the flu. And I think many people obviously get their annual flu shots and they feel like maybe that's all they need to do. But what should the public keep in mind in terms of new flu vaccines or the need to vaccinate annually against the flu or not?
Yes, well, I think that in public health, we communicate fairly frequently the need to use vaccination as a method of prevention against viruses, and influenza is one of them. COVID-19 obviously is another, and there are a number of other viruses that have actually increased life expectancy for kids past the age of 1. Before many of these vaccines, we had kids who would not make it to the age of 1. And I think with the advancement of science and medical technologies, we have been able to make vaccines available. And so to the extent that people have that in mind, the benefits of vaccines and really the protection that they provide, and frequent visits to a primary care provider or even public health departments, which do have sometimes vaccine clinics available for the public at lower cost or sometimes even free, really provide an opportunity for people to get that prevention. And one of the questions I get is, well, when do we know when these vaccines should be obtained, or when should we get these vaccines? And in terms of understanding the timeliness, especially with COVID, for example, when we're learning when COVID is around the most, I would say that our local public health departments have a lot of communication about this, that it's very tailored to the area or region that one is in. So if you're located in the US, that's a great place to get information. And then of course, journals like Apoorva will share stories, as she mentioned, right, about the summer wave. And so keeping a finger on the pulse of what's in the news, and if you hear that there is a wave coming or we're in the middle of a wave, it might be a good idea to check with the local primary care provider or the public health department to check in about vaccines.
We have a question in the chat from Emma Smith, and I'd like Dr. Kozik perhaps to respond to this one. It says, why is it that COVID has both a winter and summer bump, while influenza tends to only have a winter bump? Is there a sort of a pattern or a wave to the variants, and is that something public needs to stay on top of?
So I think that, at least to the best of my knowledge, we don't really understand exactly why certain viruses have different seasonality patterns, even though we've known or recognized that there is some sort of seasonal pattern to viral spread. There is some evidence that it has something to do with the environmental conditions. It could be maybe temperature or humidity or different climate-related aspects that make it more or less likely, or make viruses more or less likely to move around through populations. But as far as why influenza has, a certain pattern and COVID has another pattern, I don't think we know exactly why that is yet. But I think that it highlights one of the major things that I think the public needs to know, which is that even though early on there was a lot of comparative language between COVID being like influenza, or it's like the flu, or it's like a flu, I think that driving home the message that, as far as the biology is concerned, that's not really the case. These are two distinct, very distinct viruses, and they behave somewhat differently. As we've heard, SARS-CoV-2 is mutating more rapidly than influenza is. And so there is really that need to be, for the public to be ready to, or know that the information is going to change. Like, these variants are going to continue to be a topic as the virus continues to evolve, and that we can best protect ourselves if we keep up with that evolution through these updated vaccinations that will continue to develop.
Apoorva, another challenge, I think, for the public is truly understanding and absorbing what the research means. For example, when I look at one of your recent stories where you talked about the New England Journal of Medicine research that suggests that vaccination can lower the risk of long COVID. How can journalists do a better job of explaining what lower risk means, while also stressing that people need to take these risks seriously?
Yeah, it's a tough challenge sometimes, because people like to think in binaries. So if you want to write about the vaccination lowering the risk of long COVID, there are always people who want to read that and will read that no matter how you write it as vaccine. If you get the vaccine, you won't get long COVID. And the challenge is in explaining it's very effective at bringing down your risk, but it's not a get out of jail pass. Like, it's no guarantee that you will not get long COVID if you're vaccinated. And like, I see that even in the comments to the articles or on social media when I post articles, that people will say, "Oh, you're lying because I was vaccinated and I got long COVID." So the trick is in explaining the risk in a way that doesn't confuse people and doesn't, lead people to sort of misunderstand what the risk actually means to them. People are notoriously bad at figuring out what personal risk is for anything. And so I try not to use too many numbers, because the second you start using numbers, some people's brains literally shut down. They don't want to hear about it. They don't want to think about it. And so try to explain more that you can really protect yourself in this way if you can get the vaccine, but you should still just try to avoid the virus also by protecting yourself in other ways. And so to put it into context, and to also always emphasize that there are some groups that are at higher risk, people with immunocompromised systems, or pregnant people, or older adults above a certain age, to reiterate that everybody should get the vaccine, and this is what the CDC recommends. But if you are in these particular groups, you may want to really think about how to lower your risk by being very careful.
Let's move now to what's available in terms of the latest vaccine technologies and breakthroughs. I'd like Dr. Schaffner, can you help us understand that a bit, and talk a little bit about what Lisa Krieger asked, which is the upcoming COVID and flu combination vaccine?
Well, what we're doing with the COVID vaccine at the present time is what we have done for a long time with influenza vaccine. Namely, we are updating it on an annual basis. And as I'll say in a few moments, I'll say again in a few moments, the CDC is recommending that all of us in the United States, age 6 months of age and older, receive an updated, adapted influenza vaccine, and similarly a COVID vaccine each year in the fall. The next advance we hope that will come along, my fingers are crossed, is that influenza and COVID vaccine can be combined in a single shot. Those trials, those clinical trials, are currently underway. And as I like to say to people, perhaps next season, not this fall, but next year, perhaps we'll only have to roll up one sleeve rather than two. And of course, many people will find that very, very attractive. There are other investigators who are trying to make both COVID and influenza vaccine better and better. And one of the holy grails, if you will, is trying to create a vaccine that would cover many, many mutated types, right? Creating a vaccine that we would call an almost universal influenza vaccine and a universal COVID vaccine, so that whichever variant is out there, the vaccine would cover it and perhaps provide protection then for longer periods of time than just 1 year. Lots of investigators are trying to improve both vaccines going forward. We're not there yet, but let's keep supporting that kind of science.
If I can interject here just one second as a journalist, I'm also really excited about nasal vaccines. It's something I've written about before, and something that I hope we will have at some point soon, because as you know, one of the big criticisms of the COVID vaccines is that they don't prevent infection very well. And that partly that's because we don't necessarily have antibodies where we really need them to prevent infection, which is in the nose where the virus would get into the body. And so I've been watching where we are with the development of nasal vaccines. And we've been kind of slow, I think, to develop those for multiple reasons, which I won't get into now, but I'm excited to see those go forward.
We have an interesting question from David Levine, which I'd like both Dr. Kozak and Dr. Hidalgo to address. And it's his perception about a seeming silence about the rising rates of COVID from government officials. He says he's found that doctors and their staff don't wear masks, or fewer people in New York City, where he lives, are wearing masks. So, Dr. Kozak, do you perceive that there is less of a foot on the gas, if you will, about informing the public about rising rates of COVID?
I do. So I think that it seems as though, and I mean, I know that there was a lot of, public will or desire to feel as though the pandemic is something that happened in the past and is behind us, and we don't have to worry as much about it. Our attention was, consumed with other, more pressing things that have been occurring, but I think it's important to remind people, that whereas we may be out of the, acute phase where we're really seeing like incredibly high numbers of cases and high hospitalizations and lots of deaths and complications, like this is still a very pressing, public health issue. We still don't understand all the ways in which this virus is impacting our bodies. We don't really have a lot of specific treatments for those things or preventions outside of vaccination. So it's still really important. I don't know why that there are, choices made about, what certain policies will be in certain places. But I think that it would be prudent for everyone, especially, looking a little bit down the road at the avian influenza issue, for us to really reevaluate all the tools that we have in our toolbox and reconsider how, effective masking can be, and how that's something that shouldn't be seen as a restriction or a limitation, but a really effective tool to help us reduce the spread of these conditions.
Dr. Hidalgo, what are your thoughts about this?
This is such an interesting question, and I'm conflicted with what information I have available. I'm glad I see Apurva raised her hand, and I'm really curious what she has to say, especially given what she's covered. I'm in the state of Alabama, originally from California, and I traveled to California this summer to visit family. And the mask wearing that I see in the public in California, at least in Los Angeles County, is far greater than I see in the state of Alabama. However, there are pockets where we still see a great deal of mask wearing. And I would even venture to say anecdotally that there are specific groups of people that continue to wear their masks. And so I think maybe Apurva can comment to what she's covered in terms of adoption of policies in medical settings with respect to mask wearing. But I would say that as far back as when my youngest son was diagnosed with influenza at the age of 7, we were sent home with a mask from urgent care, so that while the oral antiviral medicine took effect, we would all wear masks in the home. And this was before COVID. So I think there is a precedent for mask wearing when infected, but also for prevention. And so it was somewhat surprising to hear that it was something new that was introduced to the public or viewed or perceived as new, when we do have a long history of mask wearing for infectious disease.
Yeah, if I could just add on to that, I would like to expand on what Drs. Kozik and Hidalgo have said. Yes, at this time when there's a summer bump, get that mask out. This happens to be a KN95, get an N95 mask out. This is particularly relevant to people who are at high risk of becoming more seriously ill should they become infected. People age 65 and older, if you're frail, if you have a chronic underlying medical condition, certainly if you're immune compromised, and pregnant persons. Now's the time, if you're going indoors to crowded environments, get out that mask. And of course, you have to wear it appropriately. Like this doesn't count under the nose. Up here, it doesn't count. You have to wear it appropriately.
Dr.
I like the visual aids.
You're so entertaining. Apurva, did you want to jump in?
I don't have visual aids, and actually that was a mistake, me raising my hand. But I did write about this issue, and one thing I discovered that was pretty disturbing was that it wasn't just that the hospitals weren't enforcing mask policies. It's that even in cancer centers, where people who are really severely immunocompromised go in as patients, the hospitals were not enforcing mask policies. Their own staff were not wearing masks, and people were getting a hard time from other patients when they did wear masks to protect themselves. Um, there wasn't a lot of clarity on why hospitals were doing this or not having mask policies anyway. In actual sort of statements, they wouldn't acknowledge anything. But what emerged from some of my reporting was that they didn't want to alienate some of the patients and the client population that comes into hospitals who did not like mandates. The word mandate has become such a charged and ugly word during this pandemic, and the hospitals just didn't want to go down that path where they might make some of their clientele angry. And so they just became very conservative in their approach to masking policies. And it was really quite sad to report a couple of the stories I wrote about this, because I talked to people who are at really high risk and went into hospitals for treatments like cancer treatment and ended up getting sick from the hospital, from the staff who were taking care of them, who didn't wear masks. And so it just it has become this very contentious issue, and there's been a whole ongoing fight, actually, even within the CDC's committee that decides what kind of policy should be in place at hospitals, whether hospitals should continue to have masking in place or not, and discussions that you wouldn't really expect, actually, at this point. But because of COVID and the political nature of all of these conversations since the pandemic, we are in a place where basic infection control is now debatable.
I'd like to ask each of you to address the issue of vaccine fatigue. People like me who we get our annual flu vaccines and also have gotten boosts as they've become available. There might come a point where people think, enough already. I've done this and I don't want to have to keep doing it every week or every year or a couple of times a year. We know that the annual flu vaccine isn't necessarily 100% effective, but it does reduce the chance of having severe complications from the disease. So could each of you talk about this issue of the need to communicate to people that, it's not over and that you need to keep your vaccines updated? Dr. Schaffner, could you start?
Well, Rachel, you put your finger on a very, very sensitive and very, very important issue. And I wish I had a magic solution for this. But you're exactly correct. There, as one of my colleagues likes to say, there's vaccine ennui out there. People are indifferent to vaccines and would like for all of this stuff to be over so they don't have to keep getting, as the British say, a jab. But providing vaccines, even though they are imperfect vaccines, both influenza vaccine and COVID vaccines protect best against the most serious complications. As Apurva said previously, the vaccines still are not good enough in protecting us against the initial infection and hence milder infections, but they do prevent or provide protection against, make it less likely that we will get more serious disease that requires that we be hospitalized, be put into the intensive care unit, and we have a lower risk of frankly dying of these infections. And as I like to say, what's wrong with that, right? Waiting for perfection is the great enemy, as Voltaire reminded us, of the current good. These are good vaccines, and we can provide information. That's the basis. But we also have to address individuals' attitudes. It's how they feel about something. Information goes to the brain. Attitude goes to the heart and to your gut, right? Are you comfortable? Are you reassured? Is this what everyone in your social circle is also doing? And we have to provide that kind of reassurance and comfort that getting vaccinated is a good thing for yourself, for your family, as well as for your community. And it also helps protect those people among us who are immune compromised, who can't respond optimally to the vaccine. The CDC now tells us that basically 7% of the US population is immune compromised. How do we protect our immune compromised brothers and sisters? We protect them by getting vaccinated ourselves and providing a cocoon of protection around them as they go about their days out in the world. And that reduces the chance, I don't like to use the word risk, reduces the chance that they will also become infected. So we contribute to their protection.
Dr. Kozik, I know that, again, your work in communities of color or the Black community, we deal with a myriad of issues in terms of access and access to information, health facilities, et cetera. But what are the objectives in encouraging vaccine compliance within the African American community specifically?
So I found that, often really taking the time to explain, the why or behind the under or explaining how vaccination is the solution to a particular problem. A problem being, we have this infectious agent that is changing over time. It's changing in ways that make our immune system changing in ways that make it more difficult for our immune system to recognize it and prevent it from causing severe disease. And so one of the ways, the strategies that exist that we can, circumvent that problem is vaccination. And so I find that helping people really understand the mechanics of the science that explains why something is happening will help them understand, why it's important for them to get vaccinated. And that's something that I had lots of those conversations, with my own family and extended family, where I had to explain to them, after the first round of vaccination, and then there was the booster for Omicron, and they were like, well, I already got vaccinated. Why do I need to get vaccinated again? And so, explaining, the virus is changing. Our immune system knows what it looks like based on that first vaccine, but now it can look a little different to our bodies. And so we need to give our bodies an updated wanted photo, if you will. So usually that was the analogy that I used, was trying to compare it to a wanted poster and trying to identify the virus based on these different pieces of it. And so after explaining that, people were like, oh, that makes sense. I can understand why it's something that I will have to get, more than once as the virus continues to develop. So for me, a strategy has definitely been, trying to gauge, where are the gaps in understanding, or where is the hesitancy coming from, and then trying to speak directly to whatever that is to kind of help people feel more comfortable with the choices that they have.
Dr. Hidalgo, can you help us understand the view from the Hispanic community?
Yeah, I think that in the Latino community face many of the similar health literacy challenges, and maybe to one degree further in terms of there also being language barrier that really affected the information that was available to Spanish-speaking communities, and it extends beyond Spanish-speaking communities to all non-English speaking communities. A lot of the work that I did very early on in the pandemic was to work with people like Dr. Eleanor Murray, who's at Boston University. She's also an epidemiologist, and we worked with graduate students and undergraduate students to translate a lot of the lay science materials that we were developing in English into non-English languages, Hindi and Spanish, and a number of other languages where the communication was, quite frankly, not available, so that people could get up-to-date, accurate, evidence-based, fact-based information. And so in addition to having to combat this query and curiosity about the why and the how often and what does this mean, there was also a language barrier that was faced. And so I think one thing that I like to advocate for is that in all communication, to the extent that information, especially if it's cutting edge, especially if it means potentially life or death for people, in the case of this pandemic that we experienced with COVID-19, That for journalists, I think to the extent possible, really be intentional about making sure this information is available in other languages. And I'm privileged to be bilingual and be one of the people who was central to the communication in the early days of the pandemic. But I'm not sure that we had that advantage in all languages that were necessary to communicate with the rest of the public.
We're starting to turn the corner near the end of our discussions. I wanted to make sure that we did broach the issue of misinformation and disinformation, particularly during this hectic, fraught, and crazy election year. I want to start with Apurva, but I'd like you all to speak to this issue. What is the biggest concern or problem when it comes to people not getting the right information and not having access to enough of it?
Actually, I think my answer will bear on what we were talking about just a minute before. And very briefly, Dr. Hidalgo, we do actually have COVID articles translated into Spanish, the New York Times, so that's something at least. But one of the things I think that's really been feeding misinformation, I mean, obviously there's the disinformation, people deliberately placing wrong information. But I think the other really big problem that I've seen as a journalist covering this area is that people have stopped trusting public health agencies and public health experts. And in my experience, some of that is because we don't talk enough about the negatives, even in this own conversation, right? Let's just say vaccines are good. I write about how vaccines are good. And, we mentioned earlier, vaccinations prevent long COVID to a certain degree, and they protect the more vulnerable people in society, like older adults and people who are immunocompromised. All of that is good. But at the same time, I don't think people hear enough of the potential negatives. And there are some, right? People experience this. They know that when they go get the vaccine, they have side effects. They don't feel very good. And some of the people don't actually experience COVID to quite that extent. So they think, well, maybe I'm not even at risk of COVID. Why do I want to go get a vaccine that has some side effects that, even if it's just, me feeling terrible for a couple of days? They see that other countries have made different sets of decisions. And, we're one of the only countries where the vaccine is recommended for everybody 6 months and up. Other countries don't even really recommend it for young people now. And so people want to know, why is that? Why are we doing things differently? And recently I wrote a whole big piece about more serious side effects with COVID vaccines. Yes, they are really uncommon, but they do happen. And there's not a lot of conversation about that. And I think that has led to these gaps of information that allows conspiracy theories to flourish. When people hear anecdotal stories of so-and-so that I know had a bad reaction, and so had tinnitus now, or has had hearing loss, or had heart problems, or what have you. But I'm not hearing the government talk about that. I'm not hearing the experts talk about that. And so that, I think, really leads to this sense of I'm being lied to, or people are keeping something from me. And that allows bad actors to come in and fill the space with disinformation. That I think is incredibly hard to combat. And I don't see that getting better unless public health agencies and experts become more comfortable really addressing those potential negatives and really talking honestly about the fact that maybe some downsides for some small number of people.
Dr. Kozik, I don't want to put you on the spot in terms of your organization's ability to deal with this issue, but I wonder if you have been thinking about strategies and things that need to be done.
Yeah, so I think in my own communication efforts, like one of the challenges for me has been, dealing with the information that people encounter on social media and how the information is sourced, and really helping people, understand that just because, you read something in a post, if there's no, like, who wrote the post, like, where did that information come from? Like, how do you make sure that the information that someone tells you anecdotally is actually accurate or in line with that? And so I think because social media is, by nature is a way that we are all connected to each other, information often gains credibility because of its connection that we have, or it's coming from someone I know. And so even though they're not saying this information, like they didn't originate with it, but they're passing it along to me. So that must give it some, there's a lot of times it picks up credibility on the way as it's passed from, account to post to post. And so really working with people to say, okay, you can't just, assume that, everything that you encounter, even if, your mom sends it to you or your cousin sends it to you or a friend sends it to you, doesn't mean that that is actually accurate information. And so how to really investigate, what is this saying? Like, is it providing me with a source? I encourage people, if you're encountering something in social media, if there isn't a source or a link or something that is from a credible place, then that's probably not something that you want to share on to other people. And so the speed with which that information moves around has definitely been a challenge. And so understanding that, and for younger, for younger individuals with other platforms like TikTok in particular, there is a piece I saw recently about, I think, like 30% or 40% of younger folks are reporting getting their news or getting their information from TikTok. And it's this like the short form, platform. And there's a lot of ways that, information can be presented in a way that looks official and believable, but it may not actually be. And so one of our challenges is really trying to figure out how to engage with people about their, information and social media literacy, to understand, how information flows, how to identify, what's accurate, what's not accurate, understanding what the credible sources are and are not. That's kind of been, the area in which I've been trying to do some work in those issues.
Dr. Hidalgo, I saw you had your hand raised. Did you want to add something here?
Well, I just wanted to echo what has been said and expand or maybe underline that as scientists, I think, and maybe I'll speak for myself, it really was a steep learning curve to learn how to communicate science to the public. We are so accustomed to speaking in academic and scientific speak, which usually uses very niche terminology, long words, long sentences that can appear confusing. And I think Dr. Schaffner has really given us a masterclass in science communication today, because there is a lot to be learned about how you communicate very complicated topics with nuance to, as Apurva said, a very binary thinking audience, which we all by nature are. And so I think for me, it has been, again, a steep learning curve. I think it is for many who don't have the experience with communicating with the public. And really, I think provided an opportunity to become better skilled and connecting with audiences outside of our immediate circles in academia and medicine and science.
We are going to let the amazing Dr. Schaffner wrap the program up today. But before we do that, I'd like to ask Apurva, you raised some really interesting points about the need to perhaps do more stories about the negatives, or to sort of keep it real for the public. And so if you could quickly just give us examples of 2 or 3 stories that journalists and local communities could do or should try to pursue that might help raise awareness about the need for vaccines.
I mean, I think the story that I mentioned about the vaccine side effects, honestly, that is not a story I've seen media really cover. And I think people have stayed very far from it. And I understand partly why. It's really hard to do, because what you don't want is to fuel anti-vax messaging. And so there's a sort of natural tendency to shy away from those stories. But I would encourage my fellow journalists to actually go there and to just do a very nuanced take on the topic, but to address the very real concerns that people have, whether it's about the fact that they don't want it or they don't need it or they're worried about it or whatever it is. As a couple of the experts were talking about, you have to meet people where they are. You have to meet people where their concerns are, and you can't just pretend that those don't exist. So you have to figure out what is stopping them from getting vaccinated and actually try to address that head on. And so I would say, definitely talking about side effects in an honest way, but keeping into the broader context of the greater good. And yet you're not acting like they don't exist. These negatives don't exist. And then also, which vaccine they should get. One of the things we never really see any conversation about is the different vaccines that are out there, Pfizer versus Moderna versus Novavax, they're not all the same. They all do a pretty good job, but especially this fall, for example, Novavax is targeting a different variant of an older, more ancestral version of the variant, and Moderna and Pfizer are targeting some of the newer ones that more like the children of that variant, and they're all going to be effective in different ways, but they're not necessarily the same. They don't necessarily have the same side effect profile. Novavax is a different platform. Those kinds of things I think can help people make an informed decision in a way without talking in this very sort of broad strokes. Yes, vaccines are good. Go get any of them. It doesn't matter which one.
Dr. Schaffner, you are going to help us sort of summarize today's powerful information and also point the way forward for people who are trying to communicate this issue to the public. So let me pass the torch to you and allow you to do that.
Well, thank you very much. And as you know, I'm here as a spokesperson for the National Foundation for Infectious Diseases. As many of you know, NFID is a nonprofit dedicated to educating and engaging public, communities, as well as healthcare professionals about infectious diseases across the lifespan. And now we don't make our own vaccine recommendations, but we try to educate the public about what the recommendations are from the CDC's Advisory Committee on Immunization Practices, the ACIP. And going forward, at its June meeting, the ACIP has already recommended for COVID-19 this fall, when we have an updated vaccine, which will be available probably late September into October, that everyone age 6 months and older in the United States should receive an updated vaccine to protect against potentially serious disease this fall and winter. And similarly, we've had a recommendation for a long time for flu. Everyone 6 months of age and older ought to receive that vaccine. And there is a special reminder that for people age 65 and older, 3 specific influenza vaccines are preferentially recommended. They have a little more punch, if you will, and they get an older immune system responding better. They are the high dose, the adjuvanted, and the recombinant influenza vaccines. They're available for people age 65 and older and are also now an option for people age 18 through 64 years of age who are immune compromised because their immune systems don't respond as well to the conventional vaccine. And there are at least limited data indicating that these compromised immune systems might respond better to one of these vaccines, high dose or adjuvanted vaccines. To the next slide. There's also the option now for people age 60 and older to receive a vaccine against respiratory syncytial virus, another respiratory virus that can cause serious disease, particularly among people age who are older. Now, last year, we had what was called a shared clinical decision-making recommendation for people age 60 and older. We've had a year's worth of experience, and in June, the ACIP members said everyone age 75 and older should receive one of these vaccines if they didn't receive one last year. And people age 60 up through age 74 can still, who have underlying risk conditions, ought to seriously consider getting this vaccine. There are no recommendations for revaccination. So if you received an RSV vaccine last year, you don't need to get another one this year. And of course, we also think about protecting against pneumococcal disease. That's a bacterial infection that frequently can complicate these viral infections in producing pneumonia. Everyone age 65 and older should receive one of these vaccines. There's a new one available, so-called pneumococcal conjugate vaccine 21, which is especially tailored for adults. And of course, younger people also are eligible for this vaccine. In the next slide, these are an array of materials that are available at the NFID website that can educate the public and yourselves about these various vaccines. And I would just like to emphasize that the NFID sponsors an annual press conference, which introduces the annual influenza, COVID, and now RSV immunization series each fall. The press conference will be on September 25th this year and will feature as the lead speaker CDC Director Mandy Cohen. Other experts will participate also. There are always opportunities for journalists to submit questions and ask questions of the experts and Dr. Cohen. And I urge you to attend and take the opportunity to ask questions. Thank you very much.
This has been an important and necessary conversation for us to have during the summer wave and with the emergence of variants. And so we'll definitely be posting your slides on our website at nationalpress.org along with this conversation so that our viewers and others can learn from all of you. So I'd like to take this opportunity to thank all of our speakers, Dr. William Schaffner, Apurva Mandavali of the New York Times, Dr. Bertha Hidalgo of the University of Alabama, Birmingham, and Dr. Ariangela Kozik of the University of Michigan and the Black Microbiologists Association. Thank you all for joining us for today's webinar, and please keep an eye on nationalpress.org. We'll be having another conversation about COVID and flu and vaccines next month, so please be on the lookout for that. Thank you all and have a great day.